Welcome everyone. Thank you so much for joining this collaboration between BiteMedicine and Study Hub. It's an absolute pleasure to do another one of these. For those of you who don't know me, my name is Shoaib and I'm one of the co-founders of BiteMedicine, and we've been doing sort of a bunch of webinars and bits and pieces over the last few months. And I know Study Hub have been doing more of a sort of orthopedic musculoskeletal week. And what I wanted to focus on today was more of a focus on the knee examination and a few vivas related to that. So hopefully you'll find that useful. So as I said, you know, we will cover the basic examination today, but I mainly want to focus on a few vivas at the end, and I have two cases for you. Hopefully this shouldn't take longer than 60 minutes, and I'm very thankful that you joined on this Wednesday evening. And as always, if you have any questions, just post them in the chat and I will get to them at some point. So please do ask any questions that you have.
KFC, yeah.
If you could mute your microphones as well, just because I'm getting some feedback, that would be great. Brilliant. And just before we get started, actually, just a bit about who BiteMedicine are. So we're a medical education company. We've been doing webinars, but we also have on our website, we have a question bank and a textbook, which takes you through topics right from the first steps through to the diagnosis and pathology and therapeutics, which is what I think makes our question bank unique compared to the others. And similarly for the textbook, we have a bunch of topics on there. And I believe there is a discount code that Study Hub have available. Savannah had it last week. I can't remember it off the top of my head, but it gives you 20% off. So please do check us out. Good. And just before we crack on with the knee examination, I touched on this last week, but how to go about actually preparing for the OSCE. So what most students will do is they will go to the wards and, you know, kind of be a bit sporadic in what they find. But I think the best way to do it is for, let's say, the knee exam, come up with a list of cases which are going to come up in your exam. So there's only really, you know, there's very few that are going to come up when it comes to your knee examination. So arthritis or knee replacement. Then prepare your viva for those cases, know the signs inside out, have a viva written out, you know, how to present the signs, how to present the complications, etc. And once you've done that, nail your examination routine, practice on friends, make sure it's really slick, and then go to the wards to find patients with those specific conditions. So it's kind of doing things in the reverse order, but this is the most efficient way, I believe, to prepare for your OSCEs, whether that be for your knee station or for your cardiovascular station. Always start off thinking what cases could potentially come up and then working backwards. Okay, and just to cover some basic knee anatomy, because you need to understand this a little bit before jumping into the examination. But essentially, the knee is a hinge joint. You have the quadriceps tendon and the actual quadriceps muscle bulk. Can someone, or who, you know, a bunch of you, just name me what are the different muscles which make up that quadriceps muscle bulk there in the anterior compartment? So if you just list some, say so I'm referring to, yeah, rectus femoris, someone has said, very good. Any others? Vastus medialis and vastus lateralis, very good, and vastus intermedius, yes. So those are your muscles in the anterior compartment. And that's important to know for reasons I will come on to later. And then you have your quadriceps tendon and your patellar ligament or your patella tendon just underneath the patella. What's important to understand, and I think it's a bit tricky to get your head around, is the different ligaments in the knee. So you have your collateral ligaments, which run medially and laterally, and they provide lateral and medial stability. And then you have your anterior and posterior cruciate ligaments. So the anterior cruciate ligament stops the femur from slipping forward, and the posterior cruciate ligament stops the femur from slipping backwards. So those are the key ligaments which provide stability to the knee. And of course, you have your bones, the femur, the tibia, and the fibula. So hopefully we're all familiar with that. How are you going to start your examination? As always, inspection. So looking around the bed is the first thing you'll always do, and then you look at the patient. So medication, analgesia, look for any walking aids, because that gives you a clue as to how well the patient functions. Why is body habitus important? In what specific condition am I thinking about when I say obesity? What is obesity a risk factor for? Good, osteoarthritis. Obviously, the heavier you are, the more load you're putting through your joints, the higher the risk of those joints degenerating. So a raised BMI is a risk factor for osteoarthritis, and it's important to pick up and comment on those things because, again, some people might not actually make much of it, and if you mention it, you'll look good. Just look at how the patient's postured. If, for example, they're, they're sort of leaning to one side, suggesting they may have pain on one side, for example, any scars, any muscle wasting, because muscle wasting suggests they're not using that limb as much as they normally would, which may suggest an underlying joint pathology. Someone's asked a good question. How would you actually comment on if someone's obese? So what you would say, you'd say it to the examiner, but you'd say the patient has a large body habitus. Okay. I wouldn't mention the word obese. Scars, this is the key thing, particularly in a knee examination. I'm sure at some point in your OSCEs, you will come across a patient with a total knee replacement. So make sure you know what the scar looks like. What is the scar for a total knee replacement, also known as an arthroplasty? What would the scar look like when you look at the patient? So yeah, it's a longitudinal scar along the anterior aspect of the knee. And I have a picture of it coming up. So of course you want to look for scars, swelling. You want to assess the patella to see it's in the right place, make sure it's not dislocated. Any valgus or varus deformities, again, muscle wasting, popliteal swelling. So this is a detailed inspection. Before we did a gross inspection, but then the next thing you do is you stand the patient up and you look at them from the front. You then ask them to turn 90 degrees and you look at them laterally. You then ask them to turn 90 degrees and you look at them posteriorly. And then you ask them to finally turn 90 degrees again to look at them from the medial aspect. So you get them to essentially spin around and you take a look at them and make a show of it to the examiner that you're actually really paying attention. What are the different causes of a popliteal swelling? And why is that relevant in a knee examination? So what are the different causes? So you said Baker's cyst, and why is that relevant in a knee exam? Like, what's the big deal if a patient has a Baker's cyst? What does that point towards? What diagnosis are you likely to see in your knee examination where the patient will also have a Baker's cyst? Good. So osteoarthritis. So if the patient has osteoarthritis, they will have they may have a Baker's cyst. And you've quite rightly said popliteal aneurysm as well. Obviously, that's unrelated to what you'll see in the knee examination. That's more vascular, but that will also be a popliteal swelling. So the normal alignment of the knees, so that's normal on the left. In the middle, that's valgus. And on the right, that's varus. And those are just postures that you need to be aware of. Other things that you might see on inspection, we said a scar. So this is a recent total knee replacement scar, and it just runs along the middle of the knee, a longitudinal scar. And if you see that, you need to think that the patient has had a arthroplasty or a joint replacement. That's quite classic. I'm almost certain that that will come up in your exams at some point. So you've inspected the patient, you've stood them up, you've had a good look. The next thing you do is you ask the patient to walk. So the patient may walk absolutely fine. They may use a walking aid. They may be limping due to pain, and that's known as an antalgic gait. They may have a high stepping gait if they've got damage to the common peroneal nerve, which runs just alongside the head of the fibula, which may be damaged in trauma or during surgery, for example. There are a bunch of gaits that you need to learn for your neurological examination, and I haven't gone into them here because it's not really relevant. The main one you'll see is an antalgic gait when it comes to orthopedics. And just going over the palpation briefly. So initially you have the leg in extension and you have a quick feel for temperature. Obviously, the reason we check for temperature is to exclude an infection or a septic joint. You then want to check the quadriceps muscle bulk, and you don't actually need to necessarily do this in your exam, but you can offer to measure the quadriceps muscle bulk 10 to 20 centimeters above the tibial tuberosity. So the tibial tuberosity is a little bump on the proximal tibia just around here. You then feel along the patella and the joint lines to check for any pain. And if there is pain, that's indicative of arthritis, for example, or any meniscal damage. The next thing you do is once you've felt along the patella, so you feel along the aspect of the patella, and you feel along the lateral joint margin here and the medial joint margin here. Once you've done that, you have to assess for an effusion, and that is done via the patella tap or the sweep test. It's a bit hard for me to demonstrate how to do that, but if you, essentially the patella tap is where you just tap on the patella, and if there is an effusion, it will feel bouncy. But the best thing to do is just to YouTube these, and you can actually see them being performed. Then you flex the patient's leg and do a similar thing, feeling for the patella, feel the joint lines, have a good feel of the tibial tuberosity and the head of the fibula, and again, have a good feel of the popliteal fossa to see if there are any swellings. I've got this thing, Osgood-Schlatter disease. What age group is that commonly seen in? So if you have pain over the tibial tuberosity in a particular age group, that's indicative of this disease called Osgood-Schlatter disease. So young boys, yeah, teenagers. And what it is, if I just bring my pen up again. So the patella tendon over here inserts into the tibial tuberosity, which lies about here. So if you have tendinitis or inflammation of that insertion, that will make the tibial tuberosity very painful. And that's classically seen in young teenagers associated with exercise, and that's known as Osgood-Schlatter disease. You won't really see it in your OSCEs, but you may well see it in your SBAs. Good. Okay, which of the following is the earliest to atrophy in knee disease? So let me just pull up Menti, so don't answer in the chat. Hopefully I can bring this up. So if you go to menti.com and you type in the code at the top, 4862199, you should be able to access the question. So which of the following is the earliest muscle to atrophy in knee disuse? So let's say a patient has osteoarthritis and they're not moving their knees much. Which of the following would you expect to atrophy first? Okay, let's have a look. Good, vastus medialis. So that's why kind of understanding the anatomy is important. If you go into a station where the patient has chronic knee disease like osteoarthritis, make sure you have a good look at the quadriceps muscle bulk. The first muscle to atrophy is the vastus medialis, which is the medial bit of the quadriceps muscle bulk. So it's just the medial muscle here. And that's, sorry, not that one, it's this one here. It's the first one to atrophy. The others may well also atrophy, but they atrophy later. Obviously, tibialis anterior, soleus, and gastrocnemius are calf muscles. So we wouldn't really expect those to be atrophied. It's the quadriceps muscle bulk that you expect to be atrophied, and in particular, vastus medialis. So you've had a good palpation, now you want to move the knee. You can do that passively and actively. Passively, you should have a good range of movement from 0 to 140 degrees. You want to feel for crepitus, and that's a crackly sensation over the patella, and that's indicative of osteoarthritis. You want to check for hyperextension by just holding the patient's leg at the heel and making sure it doesn't sag. Again, actively, you just ask the patient to flex and extend their leg, and you can also ask them to do a straight leg raise. And there's a few special tests that you all need to be aware of. So to test the cruciate ligaments, you can do the drawer test. Lachman's test is a test specifically for the ACL. The posterior sag sign, I'll comment to what that is. And you can also test for the collateral ligaments by applying varus and valgus stress. To look at the meniscus, you can do McMurray's test. I'm sure you guys may well have come across these names before. I can't really show you what this is, just because it's quite complex to demonstrate without actually being there live in person. But what I'd say is just look McMurray's test up on YouTube, and in an exam, offer to do it. Don't necessarily do it straight away because it can be quite painful. So offer it to the examiner. If they want you to carry it out, then go ahead and do it. But you should definitely do the drawer test to look for ACL and PCL instability. And you should definitely do the varus and valgus stress test. So this is the drawer test here on the left. You get the patient's knee into flexion, and if you want to test for the ACL, you simply pull the leg forward or pull the lower part of the leg forward, and if you want to test for PCL instability, you push backwards. A normal knee joint should be stable and should not move, okay? But if you're having an unstable cruciate ligament, then you'll either get anterior or posterior displacement of the tibia. And that suggests that you either have an ACL problem if you have anterior displacement, or a PCL problem if you have posterior displacement. The posterior sag sign, which was mentioned here, what you do there is you literally just hold the patient's foot, allow the patient to extend their leg fully, and if they have any hyperextension at the knee joint, that suggests that they have PCL instability. So if their knee sags downwards, that suggests there's a problem with the PCL. Good. What test is being demonstrated on the left? Yeah, good, it's Lachman's test. So this is another test you can do to test for what ligament are we testing for in Lachman's test? Good, ACL. So if you've done the drawer test, you don't necessarily need to do Lachman's test because you're testing for the same ligament, but an alternative is to do this Lachman's test where you have the patient's leg ever so slightly flexed and you just pull forward. And again, if you have anterior displacement, that suggests an ACL problem. And as you can imagine, to test for the medial collateral ligament, you apply force this way. And if you have, if the knee compartment opens up a little bit, that suggests you have medial collateral instability. If you want to test the lateral ligament, you apply force that way. And again, if the lateral compartment opens up a little bit, that suggests that you have lateral collateral instability. So you end on your special tests, you've checked all the ligaments, and you're good to go. So someone's asked, what's the difference between Lachman's and an anterior draw test? So it's literally just in the anterior draw test, the patient's knee is flexed and you're pulling forward. In Lachman's, you're holding the patient's leg up off the bed a little bit. Their leg is pretty much extended, and you're pulling forward. So it's just slightly different technique. I prefer the anterior draw test. You don't necessarily need to do both. And again, how are you going to present your findings? So always get in this habit. I performed a knee examination on patient X. If you know the diagnosis, as I said last week, just commit. So I performed a knee examination on patient X who had signs suggestive of osteoarthritis. Because if you put your diagnosis right at the beginning, the examiner is going to, know that you know what you're talking about. List your positive findings, list your negative findings, and then summarize with a couple of differentials if appropriate. As I said, students always, or as I said in my previous webinar, students always struggle with the negative findings. What I say here is just learn a list of negative findings for each exam, and it's going to be the same for every examination that you do. So for every knee examination, you know the patient's not going to have septic arthritis, and you know they're not going to have a fracture or a dislocation. So you can already list those off as your negative findings for every joint examination that you do. So it's just learn those three things and then list them off for every joint exam. In a respiratory exam, for example, you know they're not going to be requiring oxygen. You know they're not going to be retaining carbon dioxide. So you can list these things off as negatives for every respiratory examination that you do. And as I said, what could come up? Osteoarthritis and knee replacement. Those are going to form 95% of your knee OSCEs. You may have a few weird and wonderful things which they may try to throw in. But if you know these inside out, then that's going to pretty much sort you out for your knee cases. Okay, so have a look at that. What's the diagnosis, firstly? So good, we've seen that scar before. It's a TKL, but tell me more. What else can you comment on? You've seen it, you've seen something at the bedside, you've had a look at the patient. I'll tell you that they also have a reduced range of motion bilaterally. So that a bilateral TKL, good. What else is going on? So that's really important. They mobilize by a walking frame. So functionally, they are impaired, and that's really important. And what scar is this representing? So that's the knee. So we've got keyhole surgery. That's correct, but what's the correct name for that? Yeah, very good. Arthroscopic surgery. So put that together and tell me what's happened to this patient. What I'm trying to say is, think of a possible cause. So if I tell you this patient is 65 years old, what came first, do you think? The arthroscopic surgery or the knee replacement? Yes, so it's not just arthroscopic surgery they've had failed arthroscopic surgery because they ended up with a knee replacement. So in your presentation, you want to pick up that they've had arthroscopic surgery, and you want to mention that that was not sufficient to control the patient's symptoms because they ended up with a total knee replacement. And even now, there's a level of functional impairment because they're still walking with a walking frame. So I know it's quite an easy case, but you need to pick up on these things. And what is the most common cause of all of these problems? Yeah, so there you go. So even though I know I've only put 3 pictures on the slide, there's actually quite a lot of information to take away. So the final bit of your presentation is suggesting what has caused all of this. And you can say, you know, this is likely due to osteoarthritis because of the patient's age. So this is how I'd go about presenting it. I performed a knee examination on this gentleman who has had a bilateral total knee replacement. My main positive findings are a walking aid by the bedside, bilateral longitudinal scars across the anterior aspect of the knees, multiple smaller arthroscopic scars, and a reduced range of movement throughout flexion and extension. My relevant negative findings are no signs of septic arthritis, no evidence of fracture or dislocation. And my findings are in keeping with a bilateral total knee replacement. Can you name some other causes instead of not just osteoarthritis, trauma, or rheumatoid arthritis? What might be some other causes? So if we had a younger patient who was bleeding into their joints, what condition is that associated with? Yeah, good. So hemophilia would be another cause for, if it was a younger patient and they had a knee replacement, then you want to think, what's going on? Could this be hemophilia, for example? But anyways, keeping it simple, list your negative findings. Say your findings are in keeping with a bilateral total knee replacement with evidence of previous arthroscopic procedures. Given the patient's age, so if we assume this patient's 65, and bilateral nature of the signs, the most likely cause is osteoarthritis. Other possible causes include trauma or rheumatoid arthritis. So just list off a few other differentials or causes rather. Okay, next question. Which of the following directions is a knee replacement most likely to dislocate? So medial lateral, sorry. Medial lateral, anterior, posterior, or none of the above. Let's see what you guys think. So most of you went for anterior. The answer is actually posterior. The reason I asked this is I got asked something very similar, if not the identical question to this in my OSCE, in my finals OSCE. So the examiner actually brought out a model knee replacement, showed it to me and said, which direction is this likely to dislocate? And the answer was posterior. And the reason is when you do a total knee replacement, you may cut through or remove the posterior cruciate ligament, giving the joint posterior instability. And to try and counteract that, the metal prosthesis does have something to try and strengthen it posteriorly, but nevertheless, sometimes, rarely, they can dislocate. And if they do, they dislocate posteriorly in the majority of cases. So this was what was shown to me in my finals OSCE, and I had never really seen one before. The examiner presented it to me and asked me, you know, what direction is this going to dislocate in? So that's something that you should now hopefully be familiar with. And that is a total knee replacement. This here replaces the femoral head, and this here replaces the tibia, the proximal part of the tibia. Something also to be aware of, what are the types of knee replacements? So you have a total knee replacement, which is shown here on the left. That's where you have both articular surfaces are replaced with a metal prosthesis. Or you can have a partial knee replacement where you only have one compartment of the joint being fixed. So in this case, the medial compartment is replaced, but the lateral compartment was left alone because it wasn't really that damaged. And this is what I was trying to get at before. What are the causes of a knee replacement? So osteoarthritis, rheumatoid arthritis, as someone's rightly said, chronic crystal arthropathies, like if you have chronic gout, if you've sustained trauma to the joint, coagulopathies like hemophilia, bleeding into the joint, that can cause osteoarthritis at quite a young age. Okay. So moving back to Menti, how long does a knee replacement last? We have 1 year, 5 years, 10 years, 20 years, or lifetime. Okay. So roughly, most of these prostheses will last around the 20-year mark. So most of you gone for 10 years there, but actually most of them do tend to last up to 20 years. But I mean, saying 10 years isn't necessarily long because most of them last somewhere between 10 and 25 years. But you hope the majority of them do last up to about 20 years or so. They don't tend to last a lifetime, unfortunately. So what are the complications? For any surgical procedure, you need to think of complications in terms of early complications or late complications. And you'll read some texts which break it down even further into like immediate, early, late, very late. But just to keep it simple, split them up to early complications and late complications. Early complications relate to those revolving around anesthesia, immediate post-operative bleeding, infection, and that can be infection of the prosthesis or just general chest infection post-operatively, for example, and venous thromboembolism. So if I was to say roughly what proportion of patients who've had a total knee replacement develop a DVT? So that's a question to you guys. What do you think? What sort of proportion of patients develop a DVT post knee replacement? So we have 10, 5%, 5%, 15%, 20%. Okay, so it depends on what source you read, but some sources say as many as 50% or even more than 50% develop a DVT post-operatively. And again, a very reasonable question someone has asked is, why do patients get a DVT? I mean, if you were to compare it to, say, removing the appendix, you know, the proportion of patients who get a DVT post-appendicectomy is far, far lower than the proportion of patients who get a DVT post-elective hip or knee replacement. So actually, if you go and watch one of these surgeries, you will see why they develop DVTs. The way they manipulate the joints, basically the way they manipulate the joints can cause venous stasis, can cause like kinking and twisting of the veins, and that can then predispose to a venous thromboembolism forming. So that's pretty much why these patients are at high risk of DVT. Later complications include dislocation, infection of the prosthesis. And if you get an infected prosthesis, that is a disaster because the cure for that is you need to take out the prosthesis and replace it again. restricted movement, and they may have chronic pain. How would you manage the patient's VTE risk? So you've just done the operation. What are you going to give them? Are you going to give them low molecular weight heparin for 28 days, aspirin for 28 days, low molecular weight heparin for 14 days, aspirin for 14 days, or warfarin for 14 days? So this is based on the most recent NICE guidelines. I think this is a bit tricky, actually. Interesting. Okay, so most of you went for low molecular weight heparin for 14 days. It's not necessarily wrong, but it's not, if you had to pick one of those answers, it's not the most correct answer. So the answer is actually aspirin for 14 days. But that, I thought that would be tricky. But I feel it's like something you should know. So let's just go on to what NICE say. So how do you manage VTE prophylaxis? According to NICE, you can either give aspirin for 14 days, or you can give low molecular weight heparin for 14 days with anti-embolic stockings until discharge. So it's not good enough to just give low molecular weight heparin by itself. You need to give them stockings as well, which is why aspirin for 14 days was the most correct answer. You can also give rivaroxaban. They don't state a time frame for this, but you can give rivaroxaban as well, or sorry, instead. For hip replacement, it's a similar sort of story. Low molecular weight heparin for 10 days, followed by aspirin for a further 28 days, or you can give low molecular weight heparin for 28 days with stockings, or you can use rivaroxaban. So you may be asked about this in your OSCE, but you most likely will be asked about this in your SBAs, about how to manage VTE prophylaxis post-orthopedic surgery. So it's definitely worth knowing. This is according to the most recent NICE guidance. Okay, have a look at that and tell me the diagnosis, what you think is going on. Try and draw as many clues as you can. Okay, so we have a walking aid. Yeah, the patient has a swollen joint. It might be an effusion. They haven't. What's the diagnosis? So remember, think about, there's only two things you're really going to be asked in your knee exam, and that's either total knee replacement or osteoarthritis. Osteoarthritis causes swollen knees. Osteoarthritis causes joint effusions. Osteoarthritis causes patients to walk with a frame. They've got crepitus. Crepitus is classic of osteoarthritis, as is reduced range of movement. They've got a palpable mass in the right popliteal fossa, so that suggests a Baker cyst. Remember, Baker cysts are associated with osteoarthritis. So basically, this patient has what looks like probably bilateral osteoarthritis because they have reduced range of movement in both limbs. Even though the right is worse than the left, it's present in both. And they have bilateral crepitus. So it's bilateral osteoarthritis, but obviously it's worse on the right. So hopefully you can put all of those clues together. You know, I'm sure all of you knew this was osteoarthritis, but just putting all of those clues together to go one step further. And again, I performed a knee examination on this patient who has signs of osteoarthritis, predominantly of the right knee, but also of the left knee is what I would say. My main positive findings are a walking aid by the bedside, a markedly swollen right knee with a positive sweep test. So remember, the sweep test suggests joint effusion, antalgic gait with a reduced range of movement through both flexion and extension, and a palpable cystic mass in the popliteal fossa, likely a Baker's cyst. Negative findings are always going to be the same in every joint examination. There's no signs of septic arthritis. There's no signs of fracture or dislocation. My findings are in keeping with osteoarthritis. This is affecting the patient's quality of life, as evidenced by the walking aid. And the most likely cause is age-related degenerative changes. There's a bunch of other causes of osteoarthritis, like trauma, like hemophilia, as we already mentioned, and you can, if it's appropriate, you can list a few of those causes. So name me some risk factors for osteoarthritis. Age, good. Obesity, that's a really important one to comment on, as we said before. What else? Steroids are a risk factor for osteoporosis. Female is a risk factor for osteoarthritis, good. So women are at high risk of developing osteoarthritis. And the other big one is joints trauma. Okay, so if you've had trauma in the past, that predisposes you to osteoarthritis. High bone density. So high bone density predisposes you to osteoarthritis. Low bone density predisposes you to osteoporosis. Coagulopathies like hemophilia, if you're bleeding into your joints, that's going to cause inflammation and arthritis. And if you have congenital joint diseases, that also predisposes you. At the very basic level, it's essentially degradation of the cartilage exceeds synthesis. And so you have loss of cartilage. You have bone remodeling. And basically what that means is you lose the cartilage, the bone starts to get damaged, and you have it grows in a particular way. How does that look on X-ray? What are you going to see? When I say bone remodeling, what are the things you're going to see on X-ray that are related to bone remodeling? Osteophytes, and what's the other one? So specifically to bone modeling, I know you get the 4 changes in osteoarthritis. Yeah, sclerosis. So subchondral sclerosis and osteophytes are caused by bone growth, okay? So when your bone starts to grow in reaction to all of these changes, you form osteophytes and you get sclerotic bone. You also have synovial inflammation, and you can develop joint instability, ligament and muscle weakness. Okay, good. So you may be asked, what would you expect to see on the hands? What is that called at the distal interphalangeal joint? Okay, and what's the one at the proximal interphalangeal joint called? Good, so you have Bouchard and Heberden's nose, and that's classic of osteoarthritis. Also, the first carpo-metacarpal joint tends to get affected, and you also have muscle wasting of the intrinsic muscles, in particular the thenar eminence. In advanced disease, you can start to get things like ulnar or radial deviation, but that is in advanced osteoarthritis. So you should be able to tell the difference between rheumatoid and osteoarthritis. What are the classical signs of rheumatoid arthritis in the hands? Swan neck, yep, symmetry, that's true. That's good. Swan neck, boutonniere, and what's the one that affects the thumb? Yeah, you get Z thumb. And you also get ulnar deviation as well. You get red hot swollen joints because they're inflamed. They can be very painful, tender, and that is obviously a very different pattern of disease compared to osteoarthritis. Okay. Next question. Which of the following would you not expect to see on X-ray in patients with osteoarthritis? Good. Subluxation. So that is classically associated with rheumatoid arthritis. The four other things are associated with osteoarthritis. So joint space narrowing, osteophytes, subchondral sclerosis, and subchondral cysts. They are all associated with osteoarthritis. Subluxation is associated with rheumatoid arthritis. So that's just all that's mentioned on that slide. How would you investigate this patient? Whenever you're listing off investigations for any OSCE, always start bedside, bloods, imaging, special tests. For osteoarthritis, the only real investigation that you'll ever need to do is an X-ray of the affected joint, and it's not even routine. You don't have to do it if the diagnosis is obvious clinically, and according to NICE, you should only carry it out if there's diagnostic uncertainty, if you want to exclude other conditions, or there's a sudden worsening in their symptoms. And if you were, say this was a younger patient and you suspect there may be an underlying cause, then you can conduct some blood tests. But all you really need to do is an X-ray of the affected joint. What are the associated X-ray changes? So osteoarthritis, loss of joint space, subchondral sclerosis, subchondral cysts, and osteophytes. In rheumatoid arthritis, you also have loss of joint space. You have joint erosions, soft tissue swelling, osteopenia around the joint, and joint subluxation. So it's a slightly different pattern of disease seen radiologically, and it's very important for you to know those differences because examiners love asking this question. Okay, so this is an X-ray of a patient's knees. Let's have a look here. What does this bright white line indicate? So that line at the joint margin is whiter than it normally would be if you were to X-ray a normal knee. So that is subchondral sclerosis. Subchondral means underneath the cartilage, and sclerosis just means sort of building up. So you're having deposition of bony tissue at the joint margins, and that's known as subchondral sclerosis. And if we look here, you have these little outgrowths of bone. What are those known as? Very good, osteophytes. And what do you think of the joint space on this knee here? So on the left knee, it's reduced, but I want you to be more specific. So it is reduced, but what else can you say? Yeah, so it's more reduced on the medial side, the medial compartment. If you look at the spacing here compared to the spacing here, it's far more reduced in the medial compartment, and you'll often see that. So very good. I'm not sure I can see any subchondral cysts necessarily on that X-ray, but otherwise all the other cardinal features are there. How are you going to manage this patient? So for any chronic condition, as I said in my last respiratory lecture, you always start off with an MDT approach to get the full marks. GP, occupational therapy, physiotherapy, you may need to involve orthopedic surgeons. So always start off by saying, I would like to manage this patient in an MDT approach, and then list off a few of those specialties. Again, whenever talking about management in an OSCE, conservative, medical, surgical. Conservative therapy, weight loss, you want to get the physiotherapist involved to do certain stretches and muscle strengthening exercises. In terms of medication, analgesia, you start off simple analgesia like paracetamol and topical NSAIDs. And then if that doesn't work, you can step up to oral NSAIDs. And finally, you can escalate to things like opioids, so to get optimal pain relief. In terms of surgery, you're thinking of either arthroscopic procedures, which are essentially keyhole procedures, or arthroplasty, which is a joint replacement. According to NICE, you should refer patients to orthopedics if they have a significantly impaired quality of life. And that's why picking up on things like walking aids is very important. So you can comment on quality of life. And when you're presenting, saying the osteoarthritis is clearly having an impact on the patient's quality of life, therefore I would consider orthopedic referral as per NICE guidelines. If you're not sure about the diagnosis, then you can refer to orthopedics. And if there's a sudden deterioration of symptoms, again, you can refer to orthopedics. And that's essentially arthritis in a nutshell when it comes to OSCEs. There's not much more they're going to ask you on the knee beyond a knee replacement and arthritis. So if you, like I said, recapping, if you make your OSCE list, which is just those two things, prepare your viva, practice the examination on your friends, go to the ward or clinic and find 5 patients with arthritis, 5 patients with a knee replacement, and once you've seen 5 of each, you'll essentially have mastered everything you need to know for your knee examination. So I hope that was useful, and if you have any questions, I will be more than happy to answer them. Just post any questions you have in the chat, or you can email me if you think of any questions later on.